Thanks, everybody. We're doing a good job, I think, making sure we get all the discussion in. If we can have Ms. McNeil come up to the microphone to move on with the proposed recommendations.
Okay, so I'll read through again the work group's proposed recommendation language. So it's a Serogroup B meningococcal vaccine series may be administered to adolescents and young adults 16 through 23 years of age to provide short-term protection against most strains of Serogroup B meningococcal disease. The preferred age for MenB vaccination is 16 through 18 years of age, and it would be a Category B recommendation.
Okay. At this point in time, one of the questions that came up is how would this show up perhaps on a schedule? Is that something that the work group has thought about, or you can help us out here?
So it hasn't been specifically discussed, but I think everyone's open to either having it show up in the actual schedule as a separate line for the vaccine. I think that's probably what would happen, and then have footnotes to explain it further.
Yes, Dr. Vasquez.
Yes, just to be clear, as a pediatrician who attends in clinics, there's a difference of having something that is on the schedule be on the footnotes versus table. I just want to clarify and just make sure we're all on the same page, because I think it's very important for practitioners trying to figure out what to counsel their patients and parents on, that we are all in agreement. This vaccine, if the vote goes for a Category B recommendation, that these B vaccines will be appear on the table and not solely on the footnote.
Right, we can work with the childhood schedule work group to put that on the schedule for next year.
Dr. Romero.
I was going to say, I'm the chair of that work group. I would make sure that we have very strong discussions about including these on the schedule itself. And this is on the table, not just a footnote.
Dr. Lehrer and then Dr. Ryan.
Just a comment, the schedules we have certain colors, and none of the colors that we have right now match this recommendation. The colors we have are recommended for all children, or catch-up immunization, or certain high-risk groups, but this doesn't fit into any one of those three categories. So we need a new color. This is breaking ground.
Dr. Schuchat.
If you go back years, we have had other options, and the schedule is voted on every year. There was, people will remember, in 2009, there was a equivalent of a Category B for HPV vaccine for boys in the period before there was additional data on outcomes, and then it became a Category A. And it was on the schedule with, I believe, a kind of hatched mark thing, but not a footnote. So the schedule committee will look at that options for all the things for this year's schedule, and then that comes back to the full ACIP in October for vote.
Dr. Reingold, and then Dr. Harrison, and then Dr. Boulanger.
A minor point, but I have in front of me two different immunization schedules. One goes through age 18 and the other starts at age 19. So presumably this has to appear on both of them, is that correct?
I would think so, yeah.
Dr. Harrison.
Since we're unclear about the duration of protection, why does it specify short-term protection?
So the work group added that language just to try to make sure that people are aware that these vaccines won't prevent all cases. And so, I mean, really, that was the rationale for adding that language in there, to make sure people were aware that protection may not be long-term and may not prevent all cases.
Dr. Boulanger?
Yeah. And I just want to thank all the survivors and family members for sharing their stories. And, you know, I think my hesitation at the moment regarding the Category A, which I could easily endorse, it's not cost effectiveness, it's safety. I think there are some red flags on the safety of this vaccine. And, you know, I wonder if possibly it would be helpful to add to this some language indicating that the committee will reevaluate the potential to make a Category A recommendation when additional safety data and effectiveness data become available. mind, that's sort of the biggest issue, right?
I think in situations like that, the institutional memory is always helpful here. That we did a very similar thing to the TDAP recommendation for pregnancy, that we specified that the safety aspects was going to be paramount to that recommendation, and we made the request that ongoing safety studies be performed. Dr. Harrison? Harriman, I'm sorry.
Okay. I just wanted to also make sure that everybody understands. I think it was clarified that VFC, the vaccine we covered under VFC, but also insurance companies would be compelled to pay also with a Category B recommendation, and I'm not sure all the speakers had that information.
Could we have a comment here, I think, from Dr. Nitesky?
Yes, hi, Mark Nitosky, AHIP. Just a few comments. First of all, AHIP does value vaccines, and they have for some time, and we do know that they offer great value. Many health plans are already covering this vaccine, as stated with comments, and we also want to make sure that as we make determinations through ACIP, we want to understand your view of their effectiveness, their cost, as well as the safety of the vaccine. Health plans would cover A and B recommendations. This is when provided in network, and also to clear grandfathered plans will still be exempt from this mandate. There are also post-approval a timeline following publication in MenB. So there would be some varied uptake with plans over the course of the following year. I would imagine that uptake in the physician office would also be variable on their view of that.
But that would be the same with a Category A as well.
A or B. Yeah. And I would say that health plans with Category A recommendations tend to be more proactive regarding promotion based on appropriate age, risk, et cetera. Those that have a B recommendation or permissive are somewhat difficult to promote broadly than the plans, whether we're promoting physicians or to the patients that may have gaps in care based on appropriate age or vaccine need.
Thank you. Dr. Kemp.
I just would like to underline the fact that it's extremely important that we collect data, not just about safety, but efficacy and carriage. And I'm wondering if we incorporate that now into the guidelines, that there, well, I don't know if we can mandate it, but it's very clearly important to guide guidelines.
Dr. Bennett, and then Ms. Pellegrini.
I think we can feel confident that will happen. This is similar to the recommendation for pneumococcal vaccine in those over the age of 65. There are a number of studies going forward to try to address the effectiveness of that recommendation, and I think this would be the same. And I don't think we actually incorporated that into the recommendation, but it was certainly a discussion.
And Ms. Pellegrini.
I think we should be honest here that none of us are, those of us who are considering supporting a B are not doing it because we're wildly enthusiastic. I think that that's exactly the right recommendation long term for this vaccine, right? This is kind of where we are at this point in time, and we need a lot more information because we just don't have what we need to get A. So in that context, I'd like to urge, number one, that the manufacturers provide us with that data as quickly as possible and with as much of the data as possible. Number two, to CDC, we really need to see how we can increase reporting, and so that we really understand the burden. And not just the numbers of cases and the numbers of deaths, but really to dig in and understand the long-term consequences. And as was pointed out, the cost to the families out of pocket, the costs in medical expenses, the survivors so many times, we know we are dealing with profound lifelong consequences. So we need to understand that and factor it in. And then third, if we do end up with a B recommendation, I think this is a golden opportunity for CDC to study the policy impact of that. So looking at how does that impact whether providers carry the vaccine and how patients take it up, and that could provide an incredibly useful case study for the future and for understanding the impact of that recommendation when we make it. So I look forward to not just having our vote today, but to revisiting it. I've got 2 more years on this committee. I hope maybe even within that time frame.
Thank you. Other comment around the table or liaison? Oh, Dr. Reingold.
So this is a minor point, but with all due respect, I would submit that this is one of the diseases where we actually do know the burden of disease. I think meningia is one of the better reported diseases in the United States. The ABC's data are very compelling and extrapolatable to the rest of the country. So I do think we need more data about effectiveness. I do think we need more data about safety. But I really have to disagree that we don't know the burden of meningococcal disease.
Other comment? Yes, Dr. Evans.
Susan Even, College Health. I guess I just want to reiterate that we as the College Health Association understand that the devastating burden of the disease, and we're really committed to education about vaccines in general, the booster dose that's needed for the quadrivalent vaccine, and you know, we're pleased that we're at the point of making some recommendations, and a B recommendation would at least make sure there's an opportunity for protection of an individual, perhaps prevent some outbreaks, and also an opportunity just for communicating with health officials and college health before the fall semester. So we have a big job ahead of us, but I think this gives us a springboard to that.
Thank you very much. Is there anyone around the table willing to make a motion on this recommendation? Dr. Campos-Oakville.
I move that we accept the wording as stated.
And a second, Dr. Rubin.
I second that.
Further discussion? Okay, I guess we will move along, and we will start with Dr. Bocchini and go to your left.
Bocchini, yes.
Kemp, yes.
Belongia, yes.
Karen, yes.
Pellegrini, yes.
Harrison, no.
Harriman, yes.
Romero, yes.
Bennett, yes.
Tempe, yes.
Rubin, yes.
Reingold, yes.
Campos-Oakville, yes.
Vasquez, yes.
And the motion passes 14-1. Thank you very much again for the meningococcal work group for excellent presentation. The committee liaisons for excellent discussion. And again, to all the public commenters, all the letter writers, all the people who provided this perspective on the values and preferences that go on beyond this table. So thank you very much. I think the next thing up will be the VFC resolution. And Dr. Santoli.
Hello there. I'm going to put forward the updated proposed resolution that's consistent with the discussion that we've had here today to show it to you. I think folks probably remember, but to remind you, this resolution actually has 2 parts. The first part is about meningococcal conjugate vaccines. The second is about serogroup B meningococcal vaccines. And the changes are only in the second section, and all the changes are marked in yellow font to make them a little bit easier for you to see. So overall, there's the purpose of the resolution is to update the resolution to allow sort of for the category B recommendation, which supports individual clinical decision-making regarding the use of serogroup B meningococcal vaccines in children aged 16 to 18 years. So again, the first section, which is all about meningococcal conjugate vaccines, there are no proposed changes. For the serogroup B meningococcal vaccines in the eligible groups section, the first bullet is unchanged with a listing of the high-risk groups, and then there's the addition of a second bullet, which says children aged 16 through 18 years without high-risk conditions may also be vaccinated. In the section on recommended schedule and intervals, The table has been updated to remove specific information that indicated this is for high-risk use. We've also added a small correction into the footnote. There's no changes to the recommended dosages or contraindications and precautions section, or to the part of the statement that reminds that as a recommendation is passed, then we would refer through links to the wording in the recommendation, except for the eligible group section. Those are the proposed changes.
Are there any questions or comments? Seeing none, is there a motion for approval? Dr. Romero, second. Dr. Keeney. Further discussion? Dr. Karen, if you would be so kind, and we can move to your right.
Karen, yes.
Alonja, yes.
Kemp, yes.
Bocchini, yes.
Vasquez, yes.
Campus Outcall, yes.
Reingold, yes.
Rubin, yes.
Tempty, yes.
Bennett, yes.
Romero, yes.
Riley, yes.
Harriman, yes.
Harrison, yes.
Pellegrini, yes.
And the VFC resolution is passed 15-0. Thank you very much, and thank you, Dr. Santoli. With that, we're having Dr. Vasquez come up to introduce us to general recommendations. I'll just put in the plug to National Meningitis Foundation, the Meningitis Angels, inherent on you to help get the word out at this point in time.
Well, this is what we would have presented in February had it not snowed. It actually didn't snow. So, as you know, the General Recommendations Work Group publishes updates to the MMWR every 3 to 5 years. Immunization issues relevant to all vaccines, topics, ad hocs that cannot be attributed to a single vaccine. And these are some of the topics included in the, or within the realm of general recommendations. And today, what we are going to vote on is the second half of the document shown here in red, specifically altered immunocompetence, special situations, updates on vaccination records, vaccination programs, and information sources. The revision process is listed here, content already reviewed, and today we need further voting for CDC clearance and publication. So today we're going to show the changes that have occurred since we last discussed the documents. We're going to talk about special situations and then major revisions to 3 sections that I already presented. And this slide just goes over in more detail what you will hear today from Dr. Strickis. I just want to take a moment to thank ACIP in general for the opportunity to serve over the last 4 years. To Andrew Kroger, who's the CDC lead, who couldn't be here today, but who is probably one of the most organized and detail-oriented persons I've ever had the pleasure to work with, and for the work group in general.
Okay, thank you very much, Dr. Vasquez, and thank you for the opportunity to present revisions to the general recommendations on immunization. And I want to thank Dr. Andrew Kroger, who could not be here today. He's traveling for leading the working group with Dr. Vasquez. I have the privilege of reporting their work today. I'll proceed section by section. The ACIP members have drafts in front of them, both in track changes and in clean copies. I'll frequently refer to page numbers and line numbers in the presentations, and these correspond to the track changes version of the document. There's one place where there's an error on the slide, and I'll point it out. I'll begin with the section on altered immunocompetence, for which many of the changes are already presented to the ACIP in June of a year ago, but I'll give some background as well. Okay. All right, Gene, help me out. I'm not getting it to advance. That one, thank you. So the sections, as Dr. Vasquez said, that we'll go over again are altered immunocompetence, which takes up about half to two-thirds of the program, special situations, vaccination records, vaccination programs, and vaccination information sources. The 2011 General Recommendations currently contain a section on altered immunocompetence. The source for revised content of the section comes from cleared ACIP, MMWR vaccine-specific recommendations, and the Infectious Diseases Society of America's position statement on this topic published in 2014. The full citation for the IDSA document, which Dr. Lori Rubin, an ACIP member, was first author, is listed here. This is an evidence-based set of guidelines that involved multiple stakeholders in its development, and prior to publication, CDC was asked to comment on potential areas that might represent a deviation from ACIP vaccine-specific statements. This is an image of the publication from IDSA entitled Clinical Practice Guideline for the Vaccination of Immunocompromised Hosts. It expands greatly upon the content in the 2011 General Recommendations on Immunization, which is why the General Recommendations Work Group incorporated as much as possible into the revised document, which you have before you, and the vaccine-specific statements. The major work of the General Recommendations Working Group has been to tease out those topics which are general in nature and to stay away from vaccine-specific recommendations as much as we could, because they might not match ACIP recommendations exactly. There are relatively few of those differences. So what are the revisions to this content? First, the IDSA identified some new conditions and some new medications under the classification of altered immunocompetence, which we added to our draft. Next, for those that were here June a year ago, you'll recall that a major change is the added weight given to the issue of vaccine effectiveness, which is described in detail in the IDSA document. This issue applies to both live and inactivated vaccines and involves the complex matter of potentially withholding a vaccine if the condition or the medication is present, and if the vaccine is withheld at one interval, is it considered safe and effective to give the vaccine after the altered immunocompetence is no longer present. Third, the general recommendations have been updated to discuss altered immunocompetence as an indication to vaccinate outside of routinely recommended ages and relies exclusively on CDC vaccine-specific recommendations. Lastly, we updated the discussion of vaccination following hematopoietic stem cell transplants using evidence from the IDSA document primarily, but also on some of the CDC vaccine recommendations. Here are some of the new additions to our list of conditions and medications described in the general recommendations. 4 conditions are listed here: interferon gamma/interleukin 12 axis deficiency, interferon alpha deficiency, interferon gamma deficiency, and the category of phagocyte function disorders, one example of which is Chidiac-Higashi syndrome. New categories of medications include induction and consolidation chemotherapy and anti-B cell antibodies, and examples of the medication rituximab. Lastly, we included patients with major antibody deficiencies receiving immunoglobulins. These are specific categories defined in the IDSA guidelines and have relevance because of either changes in the general recommendations or there are new recommendations that were not there before. I wish to emphasize this section contains language that allows physician discretion in the determination of whether any of these conditions are present. Here are some of the new recommendations relevant to these conditions. They reflect categories of vaccines that can either be administered or withheld. In most cases, this information is presented on a table on page 13 of your marked up version. Certain conditions require only the withholding of live bacterial vaccines, not live viral vaccines. These include interferon gamma/interleukin 12 axis deficiencies, but note there are also recommendations to withhold both live viral and bacterial vaccines in patients with interferon alpha deficiency and interferon gamma deficiency. Teasing out the different pathways of these interferons will be the job of the immunologist or other specialty physician, which is why it is critical we allow providers latitude in using the general recommendations language and offer referral to these specialists for clarification. For other conditions, the general recommendations borrow some of the specific rationale for withholding of live vaccines from the IDSA. For instance, patients with leukocyte adhesion defects, myeloperoxidase deficiency, and Chiari-Kagashi syndrome have specific deficits in T cell and natural killer cells that render a reduced immune response to live viral and live bacterial vaccines. So both categories of live vaccines are to be withheld for such patients. For other phagocyte deficiency disorders, such as chronic granulomatous disease, these cell lines are not deficient, and so withholding is restricted to live bacterial vaccines. IDSA also invokes some of these conditions in the context not only of concerns with safety and effectiveness of live vaccines, but also the effectiveness of inactivated vaccines. Conditions in which IDSA supports withholding both categories of vaccines include induction consolidation chemotherapy, patients with major antibody deficiencies receiving immunoglobulins, and IDSA also defines a category of conditions as high-level immunosuppression, including cancer chemotherapy, radiation therapy, solid organ transplantation, HIV infection with immunosuppressive parameters defined, and we inferred patients receiving high-dose immunosuppressive corticosteroid therapy, as well as patients receiving biologic immune modulators. The corresponding page numbers on this slide represent the locations in the track changes version of general recommendations where these medications are described. Incorporating the IDSA recommendations occurred against the backdrop of what currently is described in the 2011 general recommendations, and those recommendations already had an extensive discussion of vaccination intervals. This slide describes the specific intervals proposed based on integrating general recommendations with IDSA recommendations. For those types of conditions and medications labeled high-level immunosuppression, IDSA harmonized with the 2011 general recommendations in recommending a 3-month interval from medication to vaccine, at least with respect to cancer chemotherapy, and again, we inferred this means high-level steroid use as well. Note that there is a vaccine-specific exception of a 1-month interval between certain categories of high-level immunosuppression, notably zoster vaccine, in which a 1-month interval has been established by the ACIP vaccine-specific statement. Now these intervals vary by direction. When a live vaccine is given first, IDSA recommends a 1-month interval from the live vaccine to the medicine or condition. And for an inactivated vaccine, they prefer a 1-month preference, but 2 weeks is the full recommendation from an activated vaccine to medication use. IDSA has also introduced exceptions to the 3-month rule when the medication is given first. For example, for anti-B-cell antibody therapy, the interval should be 6 months, and for solid organ transplant rejection therapy, the evidence supports a range of 2 to 6 months for an interval, which practically could be considered a 2-month interval. The IDSA also defines a category of immunosuppression defined as low-level immunosuppression. Examples are lower doses of corticosteroids, as has been discussed in the general recommendations for some time, and alternate-day corticosteroids, as well as the examples set out in the ACIP zoster statement with defined doses of drugs such as azathioprine, methotrexate, and 6-mercaptopurine. Note the discussion of intervals and withholding vaccines are woven into the text of the new draft, such that general principles, including live vaccines effectiveness concerns and safety concerns, are both relevant, with primacy given to safety for the individual. Whereas with inactivated vaccines, there are safety concerns and effectiveness concerns. Effectiveness is the primary rationale for withholding the drug, because safety is of lesser concern that we know of. Also note that when it comes to inactivated influenza vaccine, this vaccine is frequently excluded from considerations of withholding, but that doses, if they're administered during the time of immunosuppression, should be repeated when the patient is no longer immunosuppressed. The next topic, somewhat less complex, could involve simply updating the general recommendations with content from vaccine-specific recommendations that the committee has made in the past. The changes are highlighted on page 2, beginning with slide 13, and apply primarily to the bacterial vaccines, Hib, meningococcal conjugate vaccines, and pneumococcal vaccines. These recommendations also are driven by rare conditions such as asplenia and complement component deficiency. I will note that we need to amplify the meningococcal B vaccine language to be consistent with the committee's prior recommendations. Patients who receive hematopoietic cell transplant, or HCT, also called bone marrow transplants or umbilical cord stem cell transplants, require special consideration because not only do they have altered immunocompetence, but their treatment, that is a transplant, wipes out the entire immune system, also called immunoablation. This treatment removes immune cell memory. Therefore, these patients eventually require revaccination with a complete or near complete primary series of all vaccines received prior to the transplant. Specific regimens were described in the journal Biology of Blood and Bone Marrow Transplant in 2009, and the 2011 general recommendations borrowed content from this journal and cited it heavily. CDC also placed the article on our website for reference. Reliance on this source document was vetted through ACIP for the 2011 iteration of the general recommendations. The IDSA has provided detailed recommendations for vaccination of HCT recipients in the 2014 publication, and the lead author of that prior blood marrow paper is an author on the IDSA document. Revaccination with the following vaccines is recommended post-HCT: DTaP, pneumococcal conjugate, PPSV23, Hib, Hep A, meningococcal vaccines, IPV, influenza vaccine, Inactivated, HPV, varicella, and MMR. Revaccination is not recommended where indicated with BCG, live flu vaccine, typhoid vaccines, or rotavirus vaccine, or zoster vaccine. The interval following the HCT and beginning the revaccination series varies depending on whether the vaccine is inactivated or live. The interval for inactivated vaccines is 3 to 6 months. Most are 6 months. Pneumococcal vaccine is specified as 3 months. For live vaccine, the interval is 24 months, and the responsible physician should be sure the patient is both immunocompetent and does not have or has recovered from chronic graft versus host disease. The guidance in the IDSA recommendations addresses revaccination doses following HCT, but there is little discussion about first-time vaccination following HCT, that is, administration of doses that were not received before the transplant. CDC does have specific guidance for some vaccines. Some of this guidance is unpublished, such as for zoster vaccine, Tdap, and Hib vaccine. For zoster vaccine, IDSA says vaccination is not recommended because the vaccine that should be administered is varicella vaccine post-HCT, presuming that varicella immunity had been ablated. Unpublished CDC guidance for zoster vaccine states it could be administered following a risk-benefit analysis that someone post-HCT would be exposed to varicella disease, become sick or infected, and then become a candidate for zoster vaccine. Personal communication with pertussis staff at CDC states that if pertussis-containing vaccination is not documented prior to the transplant, then post-HCT vaccination recommendations should consist of routine vaccination based on age. And finally, revaccination of 3 doses of Hib vaccine are recommended by CDC regardless of prior Hib vaccination, that is before the HCT, and these are described in the recent Hib recommendations. These sections from the draft are unchanged from the 2011 general recommendations, that is, general principles that should be determined by the physician. One of the most important is, the general recommendations identify certain categories in lab tests, but these are not meant to be all-inclusive for what the physician should assess for a level of immunocompetence. There is also a section on vaccination of household contacts of immunosuppressed persons. We added some language on the length of time for rotavirus vaccine virus shedding, and also clarified the definition of a protected environment with respect to healthcare providers to determine whether they should preferentially receive an activated influenza vaccine as opposed to live attenuated vaccine. Otherwise, the language in this section provides a strong recommendation to vaccinate household contacts of persons with altered immunocompetence, and this language is harmonized with that in the IDSA. So that's the altered immunocompetence section. I'll move to the others that are less dense and a little more straightforward. The next one is special situations. The major changes to this section since 2011 are generally unchanged since it was presented to the ACIP February of 2013. Language stating an exception to the vaccination of breastfeeding women. Breastfeeding is considered a precaution for yellow fever vaccine because there have been cases reported of apparent vaccine-derived disease in breastfeeding infants who were not vaccinated themselves, but their mothers had been. On page 6, line 33. Also, the vaccination and pregnancy section is now harmonized with the Tdap ACIP vaccine-specific recommendations on page 7, line 29. And lastly, we have kept the same language in a 2011 document regarding a physician's decision to vaccinate by the IM route for patients with bleeding disorders. They can choose to do so if they deem the bleeding risk acceptable. We'll now move to vaccination records. These changes were presented to the committee in October 2013. These changes describe the increasing capacity of vaccination registries, also known as Immunization Information Systems, or IIS, and they were described as a fully operational IIS can also prevent duplicate vaccinations, forecast when the next dose is due, limit missed appointments, allow recall for those who missed appointments, determine when vaccines need to be repeated or evaluation option, reduce vaccine waste, and reduce staff time required to produce or locate vaccination records or certificates. There is also a reference to meaningful use, defined as the capacity of an IIS to integrate its functions with other electronic health records and vice versa. And I will not read it. The language is brief, and you see it there. The section on vaccination programs outlines some programmatic aspects of immunization. This is the one spot where there's an error. It's not page 8, line 1. It should be page 1, line 6 of that section. And there's language about the National Adult Vaccination Standards, and it reads, all healthcare providers, whether they provide immunizations or not, should incorporate immunization needs assessment into every clinical encounter, strongly recommend needed vaccines, and either administer the vaccines or refer patients to a provider who can immunize, and stay up to date on and educate patients about vaccine recommendations, implement systems to incorporate vaccine assessment into routine clinical care, and understand how to access immunization information systems, that is, immunization registries. The vaccination program section is divided into a discussion of child immunization, adolescent immunization, and adult immunization. No major revisions have been made to this section on child or adolescent. However, in the adult immunization section, we included language related to the Affordable Care Act. The language you have in front of you in the draft you received prior to the meeting stated effective for private health insurance plans drafted or updated after September 2010, coverage for ACIP recommended vaccines must be covered without deductibles or copays when delivered by an in-network provider. CDC policy staff recommended the revised language in the second bullet, which you do not have except on the slide, that the Affordable Care Act, or ACA, requires insurance companies cover all immunizations that are included on the immunization schedule with no copay and no deductible. This new language does not emphasize private insurance companies. It also does not identify the fact that some insurance companies, there are relatively few, have been grandfathered out of the Affordable Care Act and do not need to adhere to it. It also does not talk about private insurance companies because government policies such as Medicare or Medicaid are not completely subject to all the provisions of the ACA. The last section I'll talk about is short, vaccine information sources. This is a listing of organizations and projects related to immunization in the United States. It includes, and I will mention them briefly, CDC Info, CDC's Contact Center, the National Center for Immunization and Respiratory Diseases, its contacts, the AAP, the AAFP, the American College of Physicians, which is a new addition, as is the American Congress of Obstetricians and Gynecologists, which were not in the 2011 edition of the General Recommendations, the Immunization Action Coalition, the Children's Hospital Philadelphia Vaccine Education Center, the Institute for Vaccine Safety, the Group on Immunization Education from the Society for Teachers of Family Medicine, the GIE, STFM, and state and local health departments. And for each group, a brief description is listed as is a link to their website. We did remove the National Network for Immunization Information because this organization, previously an affiliate of multiple partner organizations listed here, apparently is under new direction. It's unclear which organization is the parent organization or which national affiliates it has, so we chose to eliminate that from this section. That is my summary of the changes in the general recommendations. As I said, virtually all of these were discussed with the committee over the last 2 years. I'm happy to take questions and await your vote.
Thank you, Dr. Strickis. Just a point of order. the members are missing the document here. I think we've all seen that prior, before the ill-fated February meeting. Also, it was made available electronically as well. So I don't know if that poses any issue for anyone here. If it is, we could probably come back after lunch if we need to see that, or we can just proceed on at this point in time. Dr. Kemp?
Can I just propose a brief addition? We've done several surveys recently showing the knowledge about IISs, particularly among adult providers, is very negligible. I'm just wondering if under capabilities of operational IISs, there could simply be a statement made that all states have regional or state IISs, some kind of reference to that, because I think, you know, surprising but true that many providers don't know what they are.
It's fine with me, but the committee should weigh in.
Okay. Dr. Dwelly?
Yeah, I know with the mobility of our population, you know, we're a little bit more concerned about the interstate and interoperability of IISs. Was that discussed, recommendations made on that in the document?
It's alluded to, but it's not discussed in detail.
Dr. Moore.
Kelly Moore with AIM. The CDC recommendation to remove the reference to in-network providers and sort of simplify that statement on coverage may prove to be more confusing to readers than helpful. I know from an operational standpoint and dealing with people looking for coverage for their vaccines, the fact that the coverage that's required is in-network providers is critically important. Many local health departments are not yet in-network providers, and when an insured person comes to us, we have to charge them for vaccine or explain they should go elsewhere to receive it. So I'd urge the inclusion of that in-network provider clause just to prevent.
Dr. Strickis, are you able to go back to that slide?
Let's see. Oops, I think that was it. Yeah, so we had the first bullet was the language presented to the committee in the past, and we thought it was simpler to offer the second bullet, but if I understand the comment, you're favoring at least a mention of in-network providers and closer adherence perhaps to the ACA language. Is that correct?
I would prefer the original language. I think even though it is more detailed, it's more accurate, and when you're reading it, there's so much around what's covered and what's not. But that particular component about in-network providers for private is a huge deal for us, operational programs, educating the public about where to get back.
Ms. Pellegrini?
I would agree strongly with Dr. Moore. I actually prefer the language, your level of detail and accuracy. Well, would it be appropriate?
Yes.
Okay. In that case, I would make a motion to revert to the original language.
And I think we can do an does that seem like it's okay? I don't think this raises to the level of seconding and voting on this, but is that acceptable? And is it acceptable to the work group, Dr. Vaz? Okay. Dr. Bikini.
So just one addition for the revaccination post-stem cell transplant. In the yellow fever, new recommendations that included revaccination for yellow fever vaccine if the person is going to be at risk again.
Okay, so you're recommending for people at risk 24 months or more after stem cell transplant that they could receive yellow fever vaccine.
Right, it is in the current
okay.
New recommendations.
Yeah, if it's
right.
Thank you. If it's in the current recommendations, we can certainly address that.
And again, like the last edition, if we can just move that in, again, if there's general agreement, but that brings it into concert with the yellow fever vote we recently had. Other discussion? Dr. Weinbaum.
Thanks. Can we go back to the IIS slide to make sure that everybody is in agreement with the language for IIS as well?
This one, Cindy?
Yeah. Those individuals who commented on IISs. Dr. Kemp?
I was, since it's part of this is an educational resource, I think that what we've seen nationally when we do surveys is, particularly adult providers, do not know what an IIS is and need clarification that, in fact, yes, their state or region probably does have an IIS, so some kind of statement to that effect and maybe a reference to a website.
Dr. Bennett?
Yeah, I'm just curious, do we have data on how many states have adult IISs? Because
well, they don't specifically have adult, but the majority of states actually do have the ability to enter adult records. How many do? I don't know.
Yeah, I'm just curious if it's required in most states.
Dr. Moore and Dr. Hahn, I think.
Just to say, CDC does publish those data on the status of IISs annually, and my recollection is that over 40, I believe around 42, have lifelong registries where adult records can be included in those registries, including, and your point is well taken, many adult providers don't realize that, but with meaningful use and the forcing of providers to send EHR information to IISs, we're getting the word out that providers of immunizations can send their information to IISs in most states. But we really want people to use those IISs much more effectively and to be aware of their capacity. So programs are certainly to educating adult providers as well about their benefits.
Dr. Hahn?
Yeah, I was going to say pretty much the same thing. I think in many states, such as mine, it is only required for children, but it's certainly available for use in adults. And certainly there's a move towards promoting IISs much more for adults. So that data should be getting more and more robust over time.
And I'll just make a comment that we have a very functional registry in Wisconsin that has a huge amount of population of data from adults. And this is something that I do use on a daily basis and is tied directly into our EPIC EMR, where you don't have to go outside the firewall to bring the data in. And my mission has been to try and encourage people not to trust the data with an EPIC, but to always go to WER because the reliability is so good there. So I think anything we can do to promote that idea. And there's a difference between a state registry being able to and a state registry actually doing so. And I think that's where we need to put a lot of emphasis. Ms. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. We've been trying to promote the IIS among midwives who are vaccinating their patients. And one of the things that we found is that the CDC website is outdated, and it's not really the CDC's fault. So I'm not sure that if we promote the CDC site for IIS, we're getting the most current data, because most states, at least the state that I live in, our public health department has been so gutted financially that they don't communicate what the current status is. So I would actually recommend that if we put something in the schedule, that it would recommend that the clinician go back to their state, try to look for their state and not necessarily go to CDC's list of who IIS.
Dr. Freihofer.
Sandra Freihofer, American College of Physicians. As most of you know, I'm a practicing physician, and I just want to tell you about something that happened this week. I was trying to determine the pneumococcal vaccination history for a patient, and I had written a prescription for Prevnar. The patient took it to the pharmacy. It was not, this was like a year ago, it was not in the immunization registry. Nothing was ever faxed to me. So we did call the pharmacy, and the pharmacy did give it. But the pharmacy is not, and this is, it's CVS. The pharmacist says that they are not the ones that put it in the immunization registry, that it goes to some big corporate office and they do it. And I just wonder if we need something in here that sort of says, that pharmacists need to do this too, because it took us like an hour to try to determine if this patient had her pneumococcal vaccination. So this is an issue.
Dr. Foster?
As with all Steve Foster,
American Pharmacists Association. By the way, as an aside, you could add our website to that list of yours also up there for immunization information. We are governed by pharmacy practice laws in each individual state. And so every state is going to be different as far as what's required as far as the registry goes. And then again, so if it is required in Georgia, if it's specifically what we're talking about, then that would be regulated by the State Board of Pharmacy for following through on that. Again, and then we go along with the complications of corporate issues that occur with it too. So we really cannot make a broad statement of how it's handled throughout the country on that. So.
Point well taken. Dr. Kemp.
I was just going to circle back. My original point was that a lot of providers don't even know about the existence of an IIS or what it is. So I guess at minimum, if we could just state that in each state or region there exists an IIS, and perhaps I think some very good points have been made. They need to be in touch with their state IIS, and if we provide information about how to do that, that might be the best. Because I want to echo what John said. In Colorado, there's pretty sophisticated use of the adult side as well. So this is highly variable. And in Colorado, CVS, Target, all of those people are feeding data into the system. So it's very variable. Thanks.
So the question is, do we need to change any language with this, or do you have an addition?
Dr. Temte?
So, one possible addition would be to say providers should be aware of state and regional IIS and requirements for reporting.
Yeah, I concur with the suggested language, and we can cite the most recent data about number of states that have the capability to include data for adults, and that, as was just stated, providers should be aware of this. I believe there's some language in the adult standards we could look at as well. So to talk about the availability and urging all providers to do that, because the current language about adults just says inclusion of adults into IIS also would be worthwhile, which is vague, and I think we can be more prescriptive.
And again, is that acceptable to everyone here? I have Dr. Bennett and then Dr. Fairhofer and then Dr. Moore.
Not to beat a dead horse, but there is a huge difference between availability and requirement. And I'm just curious where the CDC is with working with state health departments to make adult reporting a requirement.
Dr. Fairhofer? Do we?
Okay.
Dr. Shukat?
The immunization information systems strengthening has been a major priority, and CDC has been putting substantially more resources into this. We've established an intergovernmental advisory committee like a FACA, but it's actually all government, local, state, federal, that is advising about our strategic plan and priorities. We have increased the resources that the states get for IIS, as well as other third-party groups to support reporting. And there's a lot of innovative work going on, as Dr. Kemp mentioned, with the pharmacy to registry interfaces. The requirements are state-driven, so that is not something that we do. But we do think making it easier and useful is the way to go, because when it's just much easier to do patient care because you have the information about what's due and what's overdue, it's easier. And as Dr. Tempe said, the idea that you don't have to leave the application and you have bidirectional flow is really where the field is going. So I would say we're extremely supportive in terms of the dollars that we've been putting in, which have been a large amount, but the requirements would be up to the states.
Dr. Fairhofer?
Sandra Fryho for American College of Physicians. This is not about state requirements. This is about taking care of your patient. This should be a very patient-centered statement, that the right thing to do when we have so many different people giving immunizations is to get it in an immunization registry. If that's too hard, get it to the provider. But to keep it in a little pharmacy or to keep it to yourself and not share it with the world doesn't help our patients. It doesn't help the bottom line. These are expensive vaccines, and our patients need them.
Thank you. Dr. Moore.
Thank you. I want to say to CDC, we very much appreciate in the states the additional funding we're receiving to make our IISs more robust, and we're working very hard on that. I agree that this is not something to focus about requirements for use. Requirements is, for one thing, it's prohibited in the state of Tennessee under our law, the way that our registry was founded, that they can't be required to report. So instead, we make it as usable and useful and valuable to the clinician in the provision of patient care that they couldn't imagine not using it. The problem is that they don't necessarily know about it and all its wonderful benefits yet, but we're working on that. And every day we're adding more and more and more clinicians whose data are coming in from their EHRs. And that does include pharmacies. And we are very grateful for the pharmacies that are submitting their information into the IIS. We truly believe that the immunization neighborhood works best when we all know what everyone is doing. And the IIS is the heart of that neighborhood where everyone has the ability to open the door and see what the patients receive. And so we're working very hard on that, and we appreciate any support for getting people engaged regardless of the age of the patients needed. We recognize adult providers really need to be brought on board with this because with the expanding adult schedule, there's so much benefit for patient care in knowing what others have done. So thank you.
Dr. Dwelly.
Yeah, I'm from North Dakota, and we have some challenges, I know, in the interoperability of bidirectional flow of immunizations between our Native American populations and our immunization registry. And I think this is one area where our federal partners could encourage that bidirectional flow in our situations.
Other comment? Seeing none, is there anyone? We have the recommendation up here now with language changes referring to the Affordable Care Act, yellow fever in pregnancy, or yellow fever after hematopoietic stem cell transplant. Okay, and on immunization information services. Is anyone willing to make a motion? Dr. Bocchini. And a second? Dr. Vasquez. Other comment? Discussion? Seeing none, we'll ask Dr. Rubin, and we'll go to your left.
Rubin, yes.
Reingold, yes.
Campus Outcall, yes.
Vasquez, yes.
Bocchini, yes.
Kemp, yes.
Belongia, yes.
Karen, yes.
Pellegrini, yes.
Harrison, yes.
Harriman, yes.
Riley, yes.
Oh, yes.
Bennett, yes.
Empty, yes. And so I think we have a unanimous 15-0 vote for passing the general recommendations. Thank you, Dr. Strickus, and thank you again, Dr. Vasquez, for leading this group.